that now. And take it away, Kat.
All right, thank you so much, Jason. Yes, as Jason said, I'm a hospital pharmacist here in Lloydminster. I've been here since 2013, so a long time, and there's been a lot of changes in this hospital since I first started working here, and here's another one that we're trying to implement in our hospital. Jason, if you want to just monitor the chat, and if there's anything you need to yell out at me, that would be great. I'm not familiar enough with being in presenter mode for this to see everything. So if you can handle that, that'd be awesome. Let's get started. All righty. Okay, so what is the problem? When I give this presentation to other groups around the province, I have often done a little bit more about the whole, hey, like doom and gloom, antimicrobial resistance is a big problem. You guys don't really need that here, so I just wanted to do a really quick overview. I poached this picture from a Justin Kozar presentation in like 2018, and I loved it. It's surprising to me that we have known that antimicrobial resistance could be a problem since the inception of antibiotics. Sir Alexander Fleming in 1945 did note that this was a potential concern. And as we know, we are sitting at about 1.2 million deaths due to AMR worldwide currently, and it's projected that we might hit the 10 million mark by 2050, which is equal to the death toll responsible that cancer is responsible for currently. So I don't need to convince you guys of the problem, but I'm just going to tell you a little bit about how we're trying to at least fix a little bit of it here in the Lloydminster and Meadow Lake area. So we've kind of tried 4 approaches. We are working on an audit and feedback. We're working at using timeout tools, or TOTS as we call them here, education and advocacy, and I know it's not a Lloydminster and Meadow Lake specific thing, but formulary restrictions. I just want to talk a little bit about how we use them here and how we kind of like them. So let's talk about audit and feedback. So we always know that a small quality improvement focused audits can help with quality improvement work. It helps for baseline. It helps to know what you're doing is working. It kind of helps to give a good picture of what's going on. Some physicians respond very well to audit and feedback, and I always think of it as kind of like the shame tactic. So of course I got Seta Unella for any Game of Thrones fans with like the shame bell. It's kind of what I feel like a little bit when I'm giving audit and feedback results, but I try to be a little bit more tactful than Seta Unella would be. So audit and feedback, I think that when we first think about this process, we think of it being super labor intensive and something that we have to kind of start from scratch. We have to make our own methodology. We have to make everything. We have to make data collection tools. We have to do all these things. That is actually not the case. We have access to the National Antimicrobial Prescribing Survey here in Canada. So this was a program that was made initially in Australia, and we've kind of adopted it in Canada as far as I understand. So it's the wonderful things about NAPS is what NAPS for short is what I'll call it, is that it's a national database and it allows for benchmarking, which I thought was a really, really great thing until I went to go benchmark my 2024 data, and the system actually wouldn't even allow me to benchmark against anybody because they need 3 hospitals in the country to submit data, and there was only 2. So if anybody wants to submit some NAPS data, I would love that so that I can benchmark against you and then, you know, maybe like shame my physicians a little bit more in a very nice way. The nice thing about NAPS is it has a really well-defined methodology. It has like a 20-page user guide that pretty much tells you everything you need to know. It tells you if you should be doing point prevalence surveys, or if you should, like, it tells you the type of survey that you should do based on the size of your hospital. So we decided on a repeat point prevalence survey in Lloydminster. So what that means is that we pick a day and we look at every case of antibiotics in the hospital on that day. And because we're a smaller center, we have to repeat that until we get 30 cases, which is the minimum. So we actually got about 50 patient charts or 50 cases, and I think 98 antibiotics with 2 separate audit days in our hospital. So it didn't actually take much. It's nice it's a web-based platform, so you can bring your phone and do it. You can bring your laptop from home if you don't have enough computers in your facility, so you can do it on anything that has access to the internet. It's already cleared by SHA privacy, or so I understand, so you don't need to worry about that. It can be tailored to a small hospital or a big hospital. An audit can be done with as few as 30 charts. We aimed for a little bit more just because we were trying to do some project development, but only 30 is the requirement every year to have like a good, robust idea of what's going on in your hospital, according to the NAPS database. The thing I really, really like about NAPS is that it assesses not only the number of antibiotics that you have, but also the appropriateness of the antibiotics. So there's this really, really nice table that's at the end of the user guide of the NAPS, that tells you how to assess if antibiotic regimen is appropriate or not. So it tells you, and it is based on local guidelines, so we just applied our local guidelines and just followed this table to see where the antibiotic use would fit. And it really helps to make things hopefully a little bit less biased, a little bit less, I mean, there definitely could be some bias involved in like how sticky you are with the definitions, but it did help it to make it a little bit more regimented and a little bit more reproducible, which is really good, especially if you're going to be benchmarking against other places in the country. All right, so what were our results? So we did an audit in September of 2024, and on day one of our audit, which is the only day that we take prevalence data from, apparently, 50% of our patients had received an antibiotic in the previous 24 hours, which again, I think is a lot, but I don't know because I don't have anybody to benchmark against. Seems like a lot though. When talking about compliance with guidelines, 40% of our antibiotic use was compliant with guidelines. And when I say guidelines, again, I mean first line is where we went first. If first line didn't have any recommendations, then we went to bugs and drugs because it's a little bit more local. And if bugs and drugs didn't have anything, then we kind of just went to up to date just because it was broad. I know it's American, but at least it could kind of tell you like, hey, this is a disease state that should require antibiotics or shouldn't. And we were able to use that nicely. We had quite a few cases, 15% of our cases that were not accessible because we simply didn't know what the antibiotic was for. All right, I already talked about that, yes. Okay, appropriateness. So appropriateness, we found that we had 45% of our cases were appropriate, 40% were inappropriate, 12% were not accessible. Now this kind of comes into play. It's a little bit different than following local guidelines, and I'll give you an example. So in local guidelines for community-acquired pneumonia, we can use ceftriaxone 1 gram IV daily plus or minus azithromycin. Now, that's following guidelines. And when we look at optimal or adequate or inadequate use of the antibiotic, in the NAPS guidelines, they actually say that if a patient is able to take medications by mouth, they should be. So then we actually jumped to the first-line recommendations for PO antibiotics for CAP, and if the patient wasn't on a PO antibiotic, then we actually kind of like ding them. I think that put them into suboptimal therapy. So there's a little bit of a difference in the NAPS framework between following guidelines and being actually optimal therapy. All right, most commonly prescribed antibiotics. Ceftriaxone was our most common. That is no surprise to me. Followed by Cipro. We use, like it or hate it, we use a lot of Cipro in our surgical cases. I was actually surprised. I thought we would have more PIP-TAZ up there, but it kind of was a little bit farther down the list. So what I really like about that, oh, and just kind of as a disclaimer, all of these tables were just made for me by NAPS. I just pushed a button and it just generated all these tables. Like I didn't have to do any data analysis for this. So NAPS is really awesome and it's really easy. That being said, I was very surprised to see that amoxicillin clavulanic acid was actually not our most used product, but our most inappropriately used product. So as you can see down kind of three quarters down the way, oh, I have a cursor, I can do this. So just kind of right there. Yeah, so like all of our cases of amoxiclav were inappropriate. My guess in regards to that is that if we are successful in a step down to PO therapy, then the physician often wants to give like 7 days of the oral therapy regardless of the IV therapy that the patient was on previously. So that might be a little area that we can look into, and we have been trying to look into. All right, so our indication-wise, again, another beautiful table that was made by NAPS. As you can see, most of our most common indication was unknown, and community-acquired pneumonia was our second most common indication. Actually, something that we apparently treat a little bit more optimally than some of our other disease states, which isn't surprising because we have done some focused work on community-acquired pneumonia in the last few years, so I'm glad to see that it's looking okay. Cystitis, obviously, we have a bit of work to do, and surgical prophylaxis, we have a lot of work to do, it looks like. Okay. Documentation, again, beautiful graphics made by NAPS for me here. In 25% of cases, the indication was documented, which explains the problem, some of the problems that we have with antibiotics. We very rarely know why an antibiotic is being given, and especially it comes to light because we have a hospitalist program here and we change over every Wednesday, and the changeover doctors like, hey, what's this antibiotic for? And we like have no idea. So it's something that we have been speaking with the hospitalists about, and I'm hoping that we'll see some improvement in our next audit. Review or stop date was documented in 40% of cases, and keep in mind that this is including one-time doses. So one-time doses would make up some of the 40%. Just kind of keep that in the back of your head. Surgical prophylaxis given for greater than 24 hours in 2/3 of the cases. So again, something for us to look at. Now these graphics I actually made, the NAPS, I couldn't figure out how to make these kinds of reports, and maybe it can't, but I was able to download all of the raw data from NAPS fairly easily. So I wanted to look at a breakdown of physician groups, just so I could present the different groups and show them their different information. So for example, hospitalists, they're kind of middle of the road. Actually, surprisingly, surgeons did pretty darn good. 75% of their antibiotic use was appropriate. So when I think about surgical prophylaxis, and I was thinking about, oh my goodness, we have to get on our surgeons to think about this. And then I was looking at the data, and I was like, no, all of the inappropriate surgical prophylaxis was actually in the obs-gyne end of things. So now I know that I will have to tailor our education or some of our projects towards obs-gyne rather than general surgery, which was interesting to note. And our internists actually had one of our higher levels of inappropriate use. Probably just, I guess they see the most complex cases, but often don't explain what they're doing, which may have contributed to that. And then I did a presentation with the hospitalists a few weeks ago, and I actually just broke it down by hospitalist as well. So I didn't put their names on the presentation. I wasn't really sure how to present this information and not cause like excessive shame. And I was actually talking to Kristen Schmidt about this a couple months ago, and she's like, give them code names. I was like, yes. So I gave everybody a code name, and I said, if you're interested in learning about which code name you are, come find me. No one has come found me yet, but that's all right. So, but I mean, most of the hospitals were actually pretty much around the same mark. Most of them were kind of 40% of their antibiotic use was deemed inappropriate. 60% of it was, or pardon me, 40% was deemed appropriate, and 60% was deemed inappropriate. We do have one hospitalist, Hermione, there, whose use was all 100% appropriate. And when I look back at the data and think about the doctors I work with, it's not surprising. Okay. So how did they respond to this presentation? They responded well to previous audits that we've done. We did a CAP audit, as I talked about before. We have done a project on Cowdy, which they've responded very well to. This is probably the most quiet presentation I've done for the hospitalists. I think that they were really, really surprised at their antibiotic use. I didn't get any I was expecting it, but I didn't get any physicians saying, well, you were just assessing them wrong. So they actually seemed kind of contrite. They seemed like, oh, that is true information and I need to change my practice. They seem kind of embarrassed. So I don't know. Maybe they think it's a whole bunch of hooey. I'm not really sure, but that's how it went for me. The other thing I get from the hospitalists is, hey, like our use isn't that great, but it's also usually at the direction of the internist. And because it's like the big internist, we can't change anything. So I am thinking about how we can reach other physician groups. Our chief of staff here is hoping to get like a nice supper going. I'll let you know how it goes. All right, so that's audit and feedback. All in all, it's provided some really great information. It was actually fairly easy to do, but what do we do with that information? So what we decided in Lloydminster to do was something called a timeout tool. So part of the NAPS audit, that like one of the data points that you click off is whether a patient has had a formal antibiotic review within the previous 3 days. Nobody in any of our hospitals had that. We don't have a program set up to do that. So we thought that maybe we would start using something called an antibiotic timeout tool. So every morning, we get a list of patients spit out from our BDM reports of patients who were started on an antibiotic 48 hours ago. Then when the pharmacists have extra time, this is like the thing that they do. They take their antibiotic timeout tool, they assess the patients, and then they either talk to the physician about what they found or leave a little note for them. So I kind of just found this antibiotic timeout tool. I think it was on the CDC website. It's actually really, really neat. So you put the patient's name, you put the date, you list their antibiotics and what day of therapy that they're on. Then you list the indication or whatever indication you can glean from the notes. And then it actually has a nice little list of indications that don't require antibiotic use. So you can just check off, oh, hey, this is an antibiotic for a patient who has no symptoms of UTI, but they're being treated for a UTI. So it has some nice little check boxes there. And then it also has a list down here of questions you should be asking yourself when you're assessing the antibiotics. Can the antibiotic be stopped? Is there no need for an antibiotic? Can the duration be limited? Can it be narrowed? Does it need to be broadened? Is there an IV to PO step down that's possible at this point in time? So we look through all these things and we make our assessment and we write a little note to the physician and sign and date it. And we actually use this as our chart note as well. So even if we speak to the physician, we still make sure to put this into the chart. Now, I thankfully was able to find this document in a Word document because I actually have changed it several times from its original form just to make it suit our hospital a little bit better. Okay, so I thought it would be important to collect data on this and see how we're doing and see if it's actually worth our time. So the team here in Lloydminster, has been amazing. They just jumped onto this idea with both feet. They've been so enthusiastic about it, and they've even been helping me with data collection, where they take a photocopy of the timeout tool, and if they know that it has been accepted or rejected, they'll make a note of that at the bottom. And if they don't know yet, like if they just had to leave the chart note because the physician had gone for the day and they're not sure what the results were, they actually leave it in the little pharmacist's office that we have upstairs, and then they will follow up on it and see, oh, hey, was this accepted, yes or no, and then they will bring all the timeout tools down to my office once they find out what the results were. So it's been amazing. So in November and December of 2024, so we have 2 floor pharmacists that work every day, just for context, and we have a 60-bed facility. So we have 40 medical patients, which was mostly where our focus has gone with this initiative, just because we have such good access to the hospitalists here. So in November and December, in our 40 beds, we evaluated 58 cases of antibiotics on the 2nd day of therapy. 12 cases were deemed to be appropriate and no change was required. We still did document that, put the timeout tool in the chart, and they still did give me the timeout tools as well. 26 recommendations were accepted, 8 recommendations were not accepted, 0 were partially accepted, and 12 cases had an unknown result. Especially at the start of our data collection, we hadn't really quite figured out how we were going to document the results of the intervention, so we've got that cleaned up a little bit, and I expect to see far less unknown cases in the next few months. Okay, so what did our recommendations mostly comprise of? The easiest one, the nicest one that we had on day 2 was an IV to PO step down with 20 cases. We actually recommended to stop antibiotics in 16 cases and to limit or assign a duration in 11. We asked to narrow the spectrum of the antibiotic in 9 cases based on guidelines alone, and suggested to do that based on culture results in 4 cases. And actually in a couple cases, 2 cases, we did recommend to extend duration. I think that was there was one for a blood infection, like a Staph aureus blood infection, and one of those cases was also for a catheter-associated UTI. So we did actually sometimes, I always wanted like stop antibiotics, but there are cases where we actually have to extend the duration, or even we didn't have to suggest to broaden any antibiotics over the last 2 months, but it is an available intervention for us to do. Now you might, if we got any math whizzes on the line here, you'll see that these numbers add up to greater than 58, and that's because I just, for ease in data collection, if a recommendation both was to narrow the spectrum and switch from IV to PO, I did just put both of those data points in. It's not perfect, but it's the way I did it. So what were our most commonly accepted recommendations? 13 cases we were able to get an IV to PO step down. 8 cases we were able to narrow, and again, some of those do kind of fall into the IV to PO step down. We narrowed based on cultures in 4 cases, extended the duration in 1 of the cases, limit or assigned a duration in 4, and actually, I mean, I think this number is amazing. We were able to stop 7 antibiotics for, most of them were for cases where the antibiotic just wasn't required. It was like kind of put on admission because nobody really knew what was going on. Then once we found out something different was happening that wasn't infective, we were able to stop it. And actually, like, I have to say, the pharmacists in Lloydminster, they have been going like absolutely to the wall with this. Like I reviewed one case where one of the pharmacists had, we got a transfer in from one of our smaller community hospitals, and the patient was on like day 10 of antibiotics. And so the pharmacist was like, what's going on? Like nobody in our hospital knew, but it had been continued. And she called the community hospital and found out like what had been going on then. And like the nurses then were even like, oh, I don't think it was really required. It was for like a high white count on one day with no like focus of infection that they could find, and then these antibiotics have been on for 10 days already and they were transferred in. So I thought, holy smokes, that took a lot of work, and she was able to stop the antibiotic, which I thought was awesome. Okay, what recommendations were most commonly not accepted? Well, I think we can all guess the recommendation to stop antibiotic was the toughest sell for us here. But I think we are kind of wearing our doctors down, which is nice. And the IV to PO step down, which I always find surprising. I always feel like IV to PO step down should be like an easy solution, but our guys here are a little bit hesitant to step down from IV to PO, which is actually really interesting because I was just at a nursing all-day ed this morning, and I was talking to them about this, and one of the nurses who had moved from Alberta, and she's like, what is up with all of your IV antibiotics in Saskatchewan? She's like, everybody in our Alberta hospitals are on oral antibiotics. And I was like, I don't know, but we'll get there. Okay, so what are the advantages of the timeout tools? They offer an opportunity to assess antibiotics. I very, very firmly believe that for us to make a difference in antimicrobial stewardship, we don't have to be experts. We just have to have the chance to give our antibiotics a little bit of a second look. And I think it's nice to have like a formalized review scheduled for each of these patients. The standardized form I have found does help. Like I feel like the physicians respond better to us saying, hey, look, there's this form that says we should do all these things that somebody official made, versus us just being like, hey, like, let's stop this antibiotic. The nice thing about the form as well is that on the back it does have the recommended duration of treatment for most common infections, which is really nice to be able to just flip over and show the doctor and say, hey, like, I'm not full of beans. There is somebody else out there that says you should treat pneumonia for 5, possibly 3 days. The thing that I really like about the timeout tools as well is that it is a service that can be dropped if we're really strapped. I know with anything in pharmacy, anything anywhere, we always think, if we have a short call, if we have a leave, if we have a vacancy, can we keep up with this service, and what will happen if we can't? The nice thing about the timeout tool is nobody was doing it before anyway, and it is sort of an extra thing right now for us. So if we have to drop down and like help in the dispensary because the technicians are short, or we have 2 sick calls, we just don't do the timeout tools that day, and that's fine. And sometimes we will actually keep the reports to follow up with the next day if we have time the next day, and sometimes it's just a full week of garbage and we just can't do it, and that's the way it is. But I also do think it kind of has helped to bring antimicrobial stewardship to a little bit more front of mind in our regular duties, and hopefully it's something that we're thinking about a little bit more. And I do feel it is making a difference. So I'm really, really happy with how it's been going so far. Some possible downfalls. Yeah, it does take time. It's like anything. Where do you find the time? We try to find the time, and we have been pretty successful so far, which is nice. And it is more documentation. It's another chart note, another thing to do. The Lloydminster team has been amazing in not only documenting, but also helping with my data collection, which I can't ask for more. Something that kind of crossed my mind a little bit as I was working the floor over the Christmas break is, you know, you see an antibiotic, it comes in on admission, and you're like, oh, that's kind of yucky. So I'm like, would I have dealt with this before, or am I just like, oh, it'll come up on the timeout tool 2 days from now? Like, am I being more complacent at admission? And I don't know. That's just something that I have to kind of grapple with myself. But all in all, I think it's a net positive. And I think that the most important thing about this is that you do not have to be a specialist to do this. Like I said, they just need a little bit of care and attention, someone to look into them. We have been really aggressively using our local guidelines, first line, bugs and drugs. But we also talk to the Stew crew. Like, we talk to Mel, we talk to Kristen quite a bit about our cases, because sometimes we just don't know. Like, you don't have to be an infectious disease specialist to do this. You just need to ask the questions. And often you'll find the answer to the questions in our local guidelines, and sometimes you won't, and that's when you can bring in the big brains from the ID world. But I think it's just to be able to look into it is the first step. Okay. Another thing that we have been working on in Lloydminster is advocacy and education in regards to antimicrobial resistance and stewardship. So we decided to do a little bit of World Antimicrobial Resistance Awareness Week activities this year. It's every November. We'll do something next November, I hope. This is a World Health Organization initiative and a chance to go blue to raise awareness. In Lloydminster and Meadow Lake, we set up a little booth with some information, and we gave out some blue candy, because blue is the color. And we served blue food at the cafeteria with a little bit of information, as well as the Meals on Wheels program got the information. I visited some high schools to do some presentations about AMR, which was actually super fun, and only one kid fell asleep on me so far, so I'm pretty happy with that. My boss, Marilyn Younghans, who's been incredibly supportive with all of these steps, she actually went ahead and used her Cricut to make a whole bunch of blue shirts for us all to wear for our WA week. And just starting today, actually, I was able to worm my way into nursing all-day education. So that the nurses were actually, they responded really well to the information. They were kind of excited about it. So I'm hoping to see a whole lot more downloads of the First Line app from our nursing staff, because I'm hoping that they will be on the bandwagon. All right, so here's just some more pictures. So we just got Erin from Infection Control in Meadow Lake, who is helping me with the presentation there. And here's just a little picture of our kitchen trays and the blue dessert that was served. So we actually served blueberry crumble for lunch on, I think it was November 21st or something. And we served blue Jello with whipped topping in the cafeteria that day. So here's just, we got Marilyn here, we have Jackie, one of our pharmacists here, just giving out some information. We all kind of tried to rotate through so we could all talk to staff and members of the public about antimicrobial resistance. And I just included some pictures of some of the other departments. So this is the kitchen department, who really helped us out. Like they went to bat for us, amazing to help us with the food. And I just put a picture of the physio department, because I had talked to all the departments a few days before and said everybody wear blue, and everybody in the physio department wore blue. So I thought that was really cool. All right, last note is formulary restriction. So formulary restriction, I know we're doing it all over the province. It's kind of like the Ringo Starr of AMS. Like, it's not exciting, it's not sexy, but it's just there. And some people I know really don't like it. I just looked at the literature a little bit to see what the literature says about it, and it kind of looks like it has mixed results as to whether or not it actually works in doing what it's meant to do. We actually do like our formulary restrictions in Lloydminster. We've been using them for 10 years. They can cause problems. Like, for example, sometimes especially our internist group will just they'll say, I'm just not consulting ID, so I just won't use meropenem, even though I think I should use meropenem, and it's on your head if the patient dies, which feels really good. But our hospitals group is pretty much on board. They know the rules. They know that calling infectious disease is not as horrendous as it sounds. They're just a phone call away, and they usually get some really, really good advice. So there are problems, but we have gotten used to them over the last decade here in Lloydminster. I do like them because I sometimes feel that, especially I'm sure this is shared everywhere, but especially in a smaller center where it's harder to recruit physicians, and because they're not officially staff, sometimes it's hard to get what you want, I guess. I'm trying to word this better, but I can't. Anyway, I feel like the formulary restrictions give us a little bit of hand. Like, we can say, hey, it's not me that's causing problems for you. It's like the formulary that's causing problems, which is kind of nice, helps us to maintain relationships, and it does eventually, I find, usually get where we need to go. And it can be super effective in Saskatchewan. I'm not going to tell you all about the Yorkton results from their outpatient clinic, but Jason, if you haven't had Yorkton on for their ambulatory care, you totally should, because they had some amazing results just by limiting their outpatient ambulatory formulary, which they shared with me. So I thought that was really cool, but for them to tell you about, not for me. So just in summary, what we've been doing is audit and feedback, or handshake stewardship or timeout tools, education and advocacy, and formulary restrictions in Lloydminster. Some other things that we haven't explored. I mean, in the literature, you see a whole bunch of cool things like bug-drug mismatch reporting, like to actually kind of push people to look at the lab results rather than them just kind of appearing passively. Pen allergy delabeling. We've done a little bit of work in Lloydminster, but we don't really have any formalized process, and maybe less focus as we could have, but it's a very exciting area that I'm hoping we can get into. Surgical prophylaxis optimization. Yeah, that's a tough one. Our physicians, our obs-gynae physicians, have very strong opinions about post-op antibiotics when it comes to certain obstetric or gynecological procedures, so that's a hill that I haven't died on just yet, but I'd certainly like to soon. order sets and more use of empiric guidelines. I know we have order sets. I know we have empiric guidelines. We just really have a lot more work to getting everybody to use them. I mean, it's actually interesting because I have done some audits in Meadow Lake as well. Not completed yet, but we have started, and they use a lot more order sets, so their results are actually quite a bit better than our results. But I don't have anything final, so I would like to be able to benchmark that information eventually. And an antimicrobial stewardship committee. We don't really have one here. We don't have anything formalized. We're all just kind of doing whatever we think. But I understand that we will be waiting for provincial direction on that, so we haven't gone down that rabbit hole too far as of yet. And that's everything for me. So I'd love any comments, questions. What do you want to know?